Good morning. Today we will having an important topic for seminar discussion. I have picked up these topics based on the theory examination, because in theory we will have some other question from this organ transplantation, but we are covering mainly three parts of this organ transplantation discussion. Today we will have Dr. Orko Rai, who is a associate professor of surgery at Calcutta Medical College, who will moderate, and along with them there will be Dr. Siddharth Shankar Mishra, who is a senior resident at MR Bangalore Hospital, and Dr. Ronit Roy, who will be coming to MR Bangalore Hospital probably by this weekend. So I have also included Dr. Ronit to get involved in our academic program. So welcome Ronit and Siddharth. And we'll have three speakers today. Dr. Mehul Patel, he is a first year junior resident at MR Bangalore Hospital. Dr. Indrani Devnath, who is a second year resident at Calcutta National Medical College, now in DRP at MR Bangalore. And Dr. Tala Azam, who is first year resident at South Eastern Hospital. So we'll have three topics for discussion. Orko, you can continue the discussion, and we'll just have, I think after each speaker, you can spend 5, because the topics are different. We can spend 5 minutes for discussion. The next speaker can start. Okay. So the first speaker will be Mehul. Yes, come.
Good morning, respected professors and my dear colleagues. I am Dr. Mehul Patel. I'll be presenting basics and immunobiology of organ transplantation. What is organ transplantation? Organ transplantation is a process of surgically removing an organ from one person known as the donor and placing it into another person known as the recipient. The goal of organ transplantation is to replace a failing or damaged organ with a healthy one. Organ transplantation can be a complex procedure that requires careful planning and coordination between medical professionals. The success of the transplant depends on many factors, including the type of organ being transplanted, the health of the donor and recipient, and the compatibility of the tissues. Definitions: transplantation is the process of taking cells, tissues, or organs from one individual and placing them into a different individual or different site of the same individual. Graft: it is the transplanted cells, tissues, or organs. Donor: the individual who provides the graft, and the recipient is the individual who receives the graft, also called the host. Types of graft: autologous graft, when the graft is within the same individual, when the graft is given from the part of the same individual. Syngeneic graft, isograft from identical twins. Allogenic graft from the same species, and xenogenic graft from different species. Transplantation antigens, MHC antigens, major histocompatibility antigens, minor histocompatibility antigens, and ABO blood groups. RH grouping is not needed. HLA1 is expressed in all nucleated cells, and HLA2 are expressed in antigen presenting cells like B cells, dendritic cells, and macrophages. HLAs are inherited from both their parents as MHC haplotypes, and they are codominantly expressed. The human leukocyte antigen function is to act as an antigen recognition units, and they are highly polymorphic. Mechanism of allograft rejection. The immune responses in allogenic transplantation is the T cell mediated rejection, antibody mediated rejection, and NK cell mediated rejection. HLA expressed by the graft cell activates the T cell. Activated T cells release cytokines and plays a crucial role in orchestrating various effector mechanisms, which includes CD8 T cells, which recognize the donor HLA class 1 antigen expressed by the graft and cause target cell death by lytic molecules such as perforin and granzyme. Graft infiltrating CD4 T cells recognize HLA class 2 antigens and mediate direct damage plus release of pro-inflammatory cytokines like interferon gamma to recruit and activate macrophages that act as non-specific effector cells. And CD4 T cells helps these lymphocytes to differentiate into plasma cells and produce alloantibodies, which bind to the graft antigen and induce target cell injury directly or through antibody-dependent cell-mediated cytotoxicity. Types of graft rejection, allograft rejections, host versus graft rejection, hyperacute, acute, and chronic, and graft. Graft versus host reaction. Hyperacute rejection, it occurs almost immediately. It is characterized by thrombotic occlusion of the graft. Pre-existing antibodies in the host circulation bind to the donor endothelial antigens. It activates a complement cascade and produces thrombosis and causes the hyperacute rejection. Uh, Seen in ABO incompatible organ grafts, kidney transplants are more vulnerable to hyperacute rejection. Acute rejection, it occurs within the first 6 months and may occur later. It is mediated by T lymphocytes. All types of organ grafts are susceptible to acute rejection, and it is usually reversible by immunosuppressive therapies. Chronic rejection, all types of transplants are susceptible to chronic rejection, and it is a major cause of allograft failure. It occurs usually in months to years. Pathology, there is fibrosis and vascular abnormalities with the loss of graft function. Risk factor for chronic graft rejection is previous episodes of acute rejection, poor HLA match, long cold ischemia time, cytomegalovirus infection, raised blood lipids, and inadequate immunosuppression. Graft versus host disease. Some donor organs, particularly liver and small bowel, contains large number of lymphocytes. This may react with HLA expressed by the recipient's tissue. Frequently, it involves skin and produces characteristic rash on palms and soles. For preventing such graft rejections, we should do HLA matching and tissue typing. HLA, A, B, and DR are the most important for predicting the outcome. 000 match is a full house or a complete match. A 012 match mismatch is match for HLA A loci, has one mismatch for HLA B antigen, and is mismatched for both DR antigens. Size is not a deal for kidney transplantation. Adult kidneys can be used for pediatric recipients and vice versa. Tissue typing. Tissue typing laboratories carries out three key tasks. It determines the HLA type of blood of both the recipient and the donor by PCR, polymerase chain reaction. Cross matching is done to exclude the presence of clinically significant circulating antibodies. Flow cytometric tests are preferred over cytotoxic cross match test. And it determines HLA specificity of circulating anti-HLA antibodies in recipients before and after organ transplantation to guide immunosuppressive therapy. Thank you.
Okay. Go back to that part of slide. Autograft, allograft. Yeah. Doctor, we can discuss for about 5 minutes. As presented quite quickly.
Actually, it has been told it is the immunobiology of organ transplantation. So you should have something about rejections. There are some phases. That is sensitization, and in every time, first of all, it is through humoral immunity and the cell-mediated immunity. T lymphocytes plays a major role. So this part you should include. It is well written in Belly Love.
And you said about autograft. What are the usual example of autograft in our practice?
Skin grafts.
Skin graft and another important is practiced very frequently is autologous blood transfusion. People who are needing blood and rare blood groups, they can donate blood, is banked, and then he goes for surgery, this blood can be used. Okay, these are all important. And in isograft, what is the advantage of isograft?
The HLA matching is
yes, it's almost same matching with a twin graft. And then you talked of that matching. You said HLA, ABO. So now with advent of a lot of immunosuppressive therapy, now there is a role for doing even a mismatch transplantation. What is the concept? Can you transplant which is not matching even?
Yes, sir. So liver grafts where HLA matching is not in liver grafts, HLA matching is not that important because the rejection is it's rare and it's very late.
You see, the recipient are enlisted, and maybe that you're not getting a person who is matching with this for longer time. In that case, there is now you have good immunosuppressive therapy. So even if the ideal is it should be a matching donor. But in circumstances, you can go for unmatched transplantation also. Yeah. But what if you just use a ABO mismatch transplantation?
So ABO mismatch transplantation will cause hyperacute graft rejections.
May. Again, may. Because ABO matching is important because already these ABO people has their own preform antibodies. What are the tests they do for planning the transplant? You said go to the slide. No, that slide for matching.
So this one not different.
Yes. Yeah.
So microcytotoxic assay,
Hmm.
mixed lymphocyte culture, flow cytometry, matching and DNA analysis.
How do you test for this first one? Known antibody to WBC of donor and recipient. How is that test done?
So recipient sera and donors lymphocytes
Cells.
taken.
Recipient sera and donor cells. They will cross match. Okay. Dr. Anything want to ask?
Nothing more to include.
Okay.
Yes, that part should be included. That organ transplant phases, phases of rejection. Some more details about the complement system and the humoral and cell-mediated antibodies. Just 2 to 3 slides, I think that's really enough.
He mentioned about hyperacute rejection. These are important. Is at what phase hyperacute rejection occurs? It can occur within minutes to hours. And then the mechanism of this hyperrejection. That means they already preformed antibodies, and then gross mismatch graft. Okay. Yeah. Okay. That is again antibody mediated rejection. Indians come? No. Indrani, how can you proceed? You are traveling probably.
Sir, I have almost reached. It will take another just 2 minutes maybe.
Okay. Then we can pass on to last part of the.
Yes, sir. Indication and contraindication of organ.
Okay. Okay. We pass on to the last speaker. Dr. Tala, you are ready?
Yes, sir, I'm ready, sir.
Okay. You share your screen and present. We will
Yes,
discuss the
sir.
Indrani part in the second.
Yes, sir, yes. Sir.
So Tala Ajam is a first year resident at South Asian Hospital. He will present on the indication and contraindication of organ transplantation. He will cover this part.
Is my screen visible?
Yeah, it's visible.
Okay. So I'll first, since I was asked to present specific organ transplantation, so I will start with liver transplantation first. So coming on to indications, we have mainly divided indications into 4 groups for liver transplantation. First of which is chronic liver disease, then there is acute liver failure, then metabolic liver diseases, which include liver-based inborn errors of metabolism, and then primary hepatic malignancy, which include hepatocellular carcinoma and hepatoblastoma. Then, so what are the most common indications? The most common indication is decompensated CLD, and these are the following common causes in adults. Number 1, alcoholic liver disease. Number 2, non-alcoholic fatty liver disease. Then chronic viral hepatitis with B or C. Then we can also have autoimmune liver diseases like primary biliary cirrhosis or primary sclerosing cholangitis. Then autoimmune hepatitis and overlap syndromes in between them. Then cirrhotic metabolic liver diseases like Wilson's disease also warrant transplantation. And the specific frequencies of these etiologies depend on geographical variations. Then this is just a summary talk from Bailey and Dove for liver transplantation regarding hepatic malignancy. So liver transplantations for hepatocellular carcinoma simultaneously treats the tumor and the underlying liver diseases. And this comprises 15 to 15% of all the transplants performed in most centers. So the most common criteria that we follow for liver transplantation for HCC is the Milan criteria, which says that there should either be one lesion of less than or equal to 5 centimeters or 3 or fewer lesions of less than or equal to 3 centimeters. So the most common tumors that require liver transplantation in children are hepatoblastoma and hepatocellular carcinoma. And these days, we are also including cholangiocarcinoma, colorectal, and neuroendocrine liver mets, for the purpose of liver transplantation.
Dr. Tala, sorry to interrupt you, but can you make your presentation full screen or rotate your screen?
Yes, sir.
Yeah, that's a little better. Thank you.
Yeah.
Okay.
That's better.
Then, sir, should I repeat, sir, or should I move?
No, it's done.
Okay. Then coming to, sir, contraindications to liver transplant. So this I have copied from shorts. Coming to absolute and relative contraindications. So the absolute contraindications are insufficient cardiopulmonary reserve or severe COPD with oxygen dependence. Then severe pulmonary hypertension with mean pulmonary artery pressure more than 35 millimeters of mercury. That is refractory to medical therapy is also a contraindication for liver transplant. And then uncontrolled infections like fungal or multi-drug resistant bacterial infections also don't warrant the need for, they are rather contraindication for liver transplant. Coming to relative contraindications, older age patients above 70 years of age are a relative contraindication for liver transplant. Then alcoholic liver disease with uncertain predictors of post-transplant relapse. We usually require 6 months of abstinence. And then if the patient is infected for HIV, that is surprisingly a relative contraindication for liver transplantation as mentioned in shorts, because district protocols may exclude patients with AIDS-related illness or a CV co-infection. Then if there is any history of malignancy, except for hepatocellular carcinoma, ideally should be cured pre-transplant with eradication of curative therapy, and absence of recurrence should be there over a certain period, up to 5 years or longer for aggressive tumors. So this is about the indication and contraindication for liver transplant. And so coming to lung transplant, so the indications include any congenital diseases like cystic fibrosis or alpha-1 antitrypsin deficiency. Emphysema COPD is another indication for lung transplant. Idiopathic pulmonary fibrosis is there. Then, if there is a primary graft failure, then we might also need to retransplant the lung rather. Then, sir, coming on to contraindications for lungs, sir, I have divided into the donor and recipient contraindications. So, coming to donor contraindications, sir, any active malignancy or any active infection or severe lung disease like severe pneumonia or acute respiratory distress syndrome may not be suitable for lung transplantation. If the donor culture is suggestive of any positive organisms, like any infectious organism, then we should not transplant lung in that patient. History of any severe chest trauma or lung injury again is a contraindication for lung transplant. So advanced age is a relative contraindication for lung transplant. Then as like other organs, HIV infection or infection with hepatitis B or C virus is a relative contraindication for the lung transplant. Then, sir, coming to recipient contraindication, some points are quite the same, like active malignancy or active infections. Other than that, sir, if the recipient is having severe heart disease, then it makes the risk of transplant to appear too high. And that's why we should exclude those patients from the process of lung transplantation. Then, sir, the significant liver or kidney dysfunction, because they may affect the patient's ability to tolerate the transplant procedure and the post-transplant care. Severe pulmonary hypertension is again a contraindication for lung transplantation. So morbid obesity is a cause because it might increase surgical risk and post-transplant complications might be there. Then active substance abuse or alcoholism again is a recipient contraindication because they may not adhere to post-transplant care and that might affect the transplant outcome. Then if the patient is not compliant with medical treatment, then also we should avoid transplanting lung in the patient. Sir, again, I have divided this into absolute and relative as well, but I've already discussed the points. Sir. Should I discuss that?
Okay, you can touch just headings.
Okay.
Active malignancy, active
So, sir,
infections.
yes, sir. So the absolute contraindications include active malignancy or active or untreated infections, severe cardiovascular diseases, severe pulmonary hypertension, advanced liver or kidney dysfunction, active substance abuse or alcoholism, again, non-compliance with medical treatment or significant irreversible multi-organ dysfunction are the absolute contraindications for lung transplant. Coming to relative contraindications, sir, advanced age or moderate cardiovascular disease or moderate pulmonary hypertension, then chronic infections or other significant medical conditions that cannot be managed or that increase the risk of surgery and immunosuppression are relative contraindications. Then in the last is psychosocial issues again is a very important relative contraindication for any transplant rather because they won't get adequate social support or significant psychiatric disorders might impact transplant outcomes. This was about sir lung transplant. Next, coming to sir renal transplant, coming to indications. So these are the following indications. Number one is end-stage renal disease, and all the kidneys have lost almost all of their functions. And the patient needs either dialysis or is approaching the need of dialysis. We can go for renal transplant. Then CKD stage 4 or 5, again because the kidney is severely damaged, the renal function is severely impaired. That's why we need to transplant renal kidney in this patient. And diabetic nephropathy or glomerulonephritis again are among the common indications for renal transplant. Polycystic kidney disease, sir, because the kidneys are filled with fluid cysts, and that might lead to kidney failure. So in severe stage of polycystic kidney disease, we also need to transplant kidney. In hypertensive nephropathy, again, like diabetic nephropathy, it can cause kidney damage because of uncontrolled high blood pressure, and that might warrant kidney transplant. Then, sir, recurrent kidney stones, because uh, if the stones are forming very frequently in kidney, it might lead to kidney damage and dysfunction. And once the kidney has been damaged and dysfunction has set in, that might warrant kidney transplant. Then some congenital kidney anomalies, including the structural kidney abnormalities present at birth, also warrant indication for transplant of kidney. And so certain systemic diseases that affect the kidneys like lupus nephritis or vasculitis can cause kidney failure and hence warrant kidney transplantation. Coming to the contraindications, again, sir, quite much the same like the previous organs, except for a few points. So the absolute contraindications include active malignancies, very active systemic infection that could jeopardize the success of transplant, significant cardiovascular diseases, any advanced liver diseases, because they again can impair transplant outcomes and they might complicate immunosuppression. Any active substance abuse or alcoholism, morbid obesity, irreversible multi-organ dysfunction, or non-compliance to medical therapy are among the absolute contraindications for renal transplant. Coming to relative contraindications, sir, chronic infections, advanced age, active psychiatric disorders, significant vasculopathy that may impact blood supply to the transplanted kidney, severe pulmonary hypertension, or history of cancer that has been cured, or other medical conditions that cannot be managed very well are among the contraindications for relative contraindications for kidney transplant. Then, sir, coming to pancreatic transplant. Sir, before moving on to indications and contraindications, I would like to discuss about the types of pancreatic transplant. So there are main four types here. Number one is simultaneous pancreas and kidney transplant. That is, both organs are harvested from the deceased donor and they are indicated for patients with chronic renal failure due to diabetes. Then pancreatic transplant alone for type 1 diabetes patients who are unaware about severe hypoglycemia. Then pancreas after kidney transplant, deceased donor pancreas transplant is done after the previous kidney transplant has already been done. And last one, sir, simultaneous disease donor pancreas and live donor kidney transplant. This is very rarely performed because logistics are very challenging when it comes to this. Then, sir, islet cell transplant is also there. That is an alternative to pancreas transplant alone for patients with hypoglycemic awareness. So what happens is that we isolate islets of Langerhans and we deliver it into the recipient portal. And results have shown improved glycemic control and protection. And then, sir, coming to indications. Indications can be categorized into those with concomitant renal failure and those without. The simultaneous pancreatic kidney transplant, that is SPK, is commonly performed for patients with type 1 diabetes and renal failure due to diabetic nephropathy. Rarely, organs for SPK come from living donors, but this approach is not widely accepted and carries significant risk to the donor. Then patients with type 1 diabetes have the option of an LD kidney, that is living donor kidney, can choose living donor kidney transplantation, followed by either a pancreas after kidney transplant or simultaneous pancreatic kidney transplant. The choice between pancreas after kidney transplant or simultaneous pancreatic kidney transplant depends on factors such as expected waiting time for an SPK and the patient's specific situation. Then other indications are SPK is indicated for type 1 diabetes and end-stage renal failure. Type 1 diabetes patients without renal failure can go for pancreas transplant alone. Then, sir, type 2 diabetes patients can also be considered for simultaneous pancreatic kidney transplant after careful selection, typically non-morbidly obese with insulin requirements of less than 1 unit per kg body weight in 24 hours. Then, sir, coming to contraindications, sir. Again, very much the same like other organs, sir. Absolute contraindications include active malignancy, severe uncontrolled cardiovascular diseases, any active or untreated infections, severe or liver disease or cirrhosis, severe respiratory severe respiratory insufficiency because it could pose a risk during surgery or recovery, and severe obesity. Then, sir, non-compliance with medical treatment, active substance abuse or alcoholism, severe neurological or psychiatric disorders, or significant irreversible organ damage or failure. Coming to related contraindications, Mild to moderate cardiovascular disease is a relative contraindication, whereas severe one is an absolute contraindication. Chronic lung diseases is a relative contraindication. If the patient is mild to moderately obese, then again it is a relative contraindication. If the infection is stable or controlled, or if the patient is having chronic kidney disease, or if the patient is an older age patient, then that is again a relative contraindication for this transplant. Then, sir, coming to intestinal transplant, sir, this is the indication I have taken from daily endurance. They will have been taken from daily endurance. So the number one indication is life-threatening complications of parental nutrition, like progressive IFALD, that is intestinal failure associated liver disease, or non-intestinal failure associated liver disease. That is assessed by biochemistry and biopsy. And combined intestinal and liver transplant is best considered in the presence of advanced liver diseases, is portal hypertension or advanced fibrosis in there. Then, if there is severe sepsis, like more than one life-threatening episode of catheter-related sepsis for which no remedial cause can be identified, or endocarditis or metastatic function infection is there, or if we are having limited central venous nexus, then very poor quality of life that is thought to be correctable by transplantation also warrants intestinal transplantation. If there is, we can also go for surgery to remove a large proportion of abdominal viscera considered untenable without associated multivisible transplantation. For example, extensive desmoid disease or extensive critical mesenteric arterial disease, or if there is any localized malignancy considered amenable to curative resection requiring extensive evisceration. For example, localized neuroendocrine tumors or particular caution should be exercised in this group, and patients should be discussed in detail. Then, where the transplant procedure is expected to preclude the possibility of future intestinal transplantation. For example, if there is loss of venous access or further human leukocyte antigen sensitization is there, then that might create a problem for intestinal transplantation. Then, where the need for subsequent intestinal transplantation is considered likely and the risk of death is increased by excluding the intestine from the graft, that also warrants intestinal transplant. Then the last one is transplantation of additional organs if needed for feasibility reasons, like renal transplantation is there, or adults and children with corrected GFR of less than 45 milliliters per minute per meter square. They might also be needing intestinal transplantation. Then coming to sir, the last one, that is heart transplant. Coming to indications of heart transplant. End-stage heart failure is an indication. Then cardiomyopathy, sir. The line which has been mentioned in short says the most common diagnosis leading to a heart transplant is ischemic dilated cardiomyopathy, which stems from coronary artery disease, followed by idiopathic dilated myopathy and congenital heart disease. Then ischemic heart disease is another indication. Congenital heart disease is an indication. Refractory ventricular arrhythmia may cause life-threatening irregular heart rhythms, which cannot be controlled with medications or other interventions, and hence they warrant heart transplant. Then severe valvular heart disease that cannot be managed with surgical repair or replacement is another indication. Recurrent myocarditis, which leads to chronic inflammation of heart muscle, can lead to heart failure, and hence it is an indication for heart transplant. Then there are certain inoperable structural heart defects which cannot be surgically corrected, and they warrant heart transplant. Then high-risk coronary artery bypass surgery, when the patient requires coronary artery bypass surgery, but there are risks associated with the procedure, then also the patient might be needing. The other patients should go for heart transplant. Coming to contraindications, sir. Same like the other organs, absolute contraindications include active malignancy, untreatable systemic infections, significant organ dysfunction, uncontrollable psychiatric disorders, active substance abuse or alcoholism, severe pulmonary hypertension, non-compliance with medical treatment, morbid obesity. Then coming to relative contraindications, sir, moderate organ dysfunction, chronic infections, or history of cancer, if there has been any history of cancer or if the patient has been treated, advanced age, then if there is moderate pulmonary hypertension and other medical conditions that may impact transplant outcomes, but they could not be addressed. And then again, the last one is psychosocial issues. So these are the relative contraindications for intestinal heart transplant. This is
Okay, Dr. Tada, a few things to note is your first year presenting first time, but keep in mind that while you are presenting, you should not make the slides so busy. There are standard guidelines for writing how many lines in the per slide. That is one. Second is you need not write the whole answer to each of the points. You can keep the points in the slide and then you elaborate that point. Okay, because your slides are too busy and it's difficult to read. Okay, so keep in mind when you present next time, you write only the points and don't write more than 6 or 8 lines per slide. That is one.
Okay.
Second is, you have given the whole gamut. If I ask you, if you take the spectra of transplantation, what is the commonest organ being transplanted in day-to-day practice?
When we are going for some kidney transplantation.
Kidney, yes.
Yes, sir.
What is the next after kidney? Because you see, transplantation is now a modality of surgery where people are doing transplant day in, day out. The commonest transplant done is a kidney. Next is lungs. Then is heart. You'll hardly find that people are going regular basis of pancreatic transplantation or intestinal transplant. They are done only in rare circumstances. Okay. So these are the three main organs which are being transplanted, and there is situation for composite heart and lung transplantation. Okay. So you have covered all the indication contraindications. And do you know how these recipients are allocated the organ? You see, there are a lot of patients waiting with the liver failure, people are into the heart failure. So, and how is this done?
I'm not aware of this.
Okay. You have heard of Roto?
Pardon, sir?
Government has appointed made a body, regional organ and tissue transplantation organization. Okay, what they do is they have a database of different prospective recipient, and that is done based on some scoring system. Okay, and then once you see now you go with the brain dead donor, suddenly you get a brain dead person, and now you have to have the patients ready for to be transplanted. Okay, so government, even India government and West Bengal government also has this sort of allocation. And this allocation is done, as you said, indications, contraindications. If they're not within the indications, then they will not be in the higher in the serial list. Because you see, the demand is high. And you just cannot allocate the organ to somebody who is not in the list, or he just come with not being assessed properly. People who are in the list, they are all allocated based on their investigations. Okay.
Yes, a few things to add regarding the presentation. You should not copy paste the tables from the book. It should be changed. Number two, one thing regarding liver transplantation in indication group, you should mention after that classification, there will be some sub-classification that indication for adults and indication for pediatrics age group. There are certain diseases which needs urgent organ transplantation for child. That is biliary atresia, alpha-1 antitrypsin deficiency, and also there is some PFIC syndrome. That is progressive intrahepatic fibrosis, commonly seen in consanguineous marriages. These are things you should change.
Okay, Tala. Present.
Sir, hello. 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 I'm sorry, sir. The network got disturbed. Hello. 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 Sir, am I audible?
Yes, you are audible.
Sir, the network got disturbed. Sorry, sir.
Yeah. And then you can start.
Good morning, sir. Myself, Dr. Indrani, and today for the next few minutes, I will be talking about the immunosuppression and its complication. Now, before going into the other details, first let us know what is the immunosuppressive drug. These are basically the agents that suppress or reduce the strength of the body against the immune system, and mostly it is used in in many autoimmune disease. And here we'll be not going into detail of that, and we will discuss about the effect of the immunosuppressive drugs in organ transplantation. And here in organ transplantation, it is used to prevent the organ rejection, as in liver, heart, or kidney transplantation and others. Now, before going into the immunosuppression, how it works, first we need to remember certain principles while doing the immunosuppressive therapy. Now, the challenge is to provide the level of immunosuppression that is sufficient to protect the graft from rejection without exposing the recipient to risk from the infection and malignancy, which is one of the major complications of the immunosuppressive therapy. And the immunosuppressive therapy should be started from the time of transplantation, from the very beginning, and should be continued from the indefinite run. And the requirement for the immunosuppression therapy is highest in the first 3 months. And however, it should be continued later on also. And the most regimes are based on the calcineurin blockage therapy and also include the steroid and antiproliferative agents. We will discuss it later. Now, these immunosuppressive agents mostly are the agents which act as different sites during T cell activation to prevent the rejection. And according to their mechanism of action, they can be classified. In the following groups. Now, this is the chart where you can see that the agents are mostly corticosteroids, azathioprine, mycophenolic acids, calcineurin inhibitors, mTOR inhibitors, anti-CD24 monoclonal antibody inhibitors, and principle and mode of action. According to the mode of action, they are categorized into the following categories. Now, sir, should I read it or just?
Yeah, enough time.
Okay. So the corticosteroid therapy, the principal mode of action is it acts as an anti-inflammatory effect. They prevent lymphoproliferative proliferation. Mycophenolic acid preparations also act by lymphoproliferative proliferation. Cyclosporin and tacrolimus, they block the IL-2 gene transcription. mTOR inhibitors, they block IL-2 receptor signal transduction. ILG, they acts as a depletion and blockade of lymphocytes. Anti-CD24 monoclonal antibodies, they target the activated T cell lymphocytes. And anti-CD52 acts by depletion of lymphocytes. Anti-CD20, depletion of B cell lymphocytes. And CTL4-4IG, they acts by blocking the T cell co-stimulation. Now, while we are choosing the immunosuppressive agents, we mostly use the cyclosporin or tacrolimus as the main agent, and this is often supplemented with anti-CD24 monoclonal antibody as an induction therapy. Now, there are two things. One is a triple therapy and one is dual therapy. And in triple therapy, where CNIs are usually combined with an antiproliferative agent and a steroid, and in case of dual therapy, the CNIs are added with either one antiproliferative agent or a steroid alone. Now, there are various side effects of these immunosuppressive agents. This is this is the drug-based side effects mostly, where we can see the corticosteroids. They are mostly the side effects of hypertension, dyslipidemia, diabetes, osteoporosis, avascular necrosis, Cushing appearance, etc. For azathioprine, leukopenia, thrombocytopenia, hepatotoxicity, gastrointestinal symptoms. For myophenolic acids, leukopenia, thrombocytopenia is the major complications. For cyclosporin group of drug, nephrotoxicity, hypertension, dyslipidemia, hirsutism, gingival hyperplasia. For tacrolimus, nephrotoxicity, hypertension, dyslipidemia, neurotoxicity, and diabetes. For mTOR inhibitors, the side effects are thrombocytopenia, dyslipidemia, pneumonitis, impaired wound healing, etc. For LG group drugs, infusion reactions, leukopenia and thrombocytopenia is mostly important. For anti-CD4, it is still uncommon. For CTL4 and 4IG, there is increased risk of PTLD, that is, but however, it is still under question. And for anti-CD52 and anti-CD20, there is infusion reaction and autoimmune disease, and for infusion reaction, pulmonary toxicity for the CD420, anti-CD420 agent. Now, this is the side effects which are drug-based, but the comprehensive or the together side effects are much more, which I will discuss now. The complication of immunosuppressant agents used for various transplantation cause various non-specific immunosuppression, and there is always increased risk of infection and malignancy. Now, if you look at the infection, the transplant recipients are always at the higher risk for the infection, especially by the virus, but also fungal infection. The risk of infection is greatest during the first 6 months. However, it can occur at any time. And therefore, the chemoprophylaxis is important for the patients who are particularly at high risk. Now, if you look at the viral infection, the risk of viral infection is highest at the first 6 months on transplantation, and it is most commonly due to the CMV. Infections are also can be there, which is HSV, BK virus, herpes zoster virus. I'll coming this later. Now, for CMV infection, the CMV infection can occur mostly either by the reactivation of the latent infection or by primary infection, which is transmitted from a CMV positive donor at the time of transplantation. Now, if a recipient is attacked by the CMV virus, then it typically presents within 4 to 8 weeks. If he is not, if there is no previous prophylaxis is taken, and the patient usually presents with high-grade fever, lethargy, leukopenia, etc. And the clinical feature may be in the form of pneumonia or in the gastrointestinal disease, hepatitis, retinitis, or encephalitis, etc. Now, for the diagnosis, we can use the PCR to detect the viral load in the whole blood, or we can do the histological examination of the biopsy material to come into the confirmed diagnosis. Now, after the diagnosis, treatment is important, and for the treatment point of view, you have the antiviral agents. Now, prophylactically, for the patient who are at high risk, we can use the vanciclovir, and once the increased viral load is detected by the PCR, we can use the ganciclovir, which is the standard mode of treatment. Now, after CMV, we have also HSV infection, which also occurs due to the reactivation of the latent infection. However, it mostly present as a mucocutaneous lesion around the mouth and genitalia, and in most of the cases, topical acyclovir can be used for the treatment of the HSV infection. Next is BK virus infection, and which is the most commonly associated with renal transplantation, and one of the major reason for the graft rejection after the renal transplantation. However, the treatment of BK virus is just to reduce the level of immunosuppression and to allow the natural immune system to control the virus. And another is herpes zoster virus. Now, in case of herpes zoster virus, the chickenpox is very much serious in patients who are immunosuppressed. But the positive thing is that that chicken virus is relatively uncommon in most of the adults. Now, after the viral infection, next we come to the fungal infection. This is most commonly caused by Pneumocystis jirovecii, and it also occurs during the first few months of the transplantation therapy, and usually patients with respiratory symptoms. Therefore, for the confirmation of the diagnosis, we can use the bronchovascular lavage fluid, or we can use the lung biopsy material and go for the further treatment and management. Now, in case of bacterial infection, the bacterial infection is highest during the first month after transplantation. And as in any other surgery, the risk of bacterial infection and bacterial contamination is very high also in case of transplantations. Therefore, broad spectrum antibiotic is used to cover the perioperative period as a prophylaxis against the wound infection and other possible bacterial contamination. Bacterial infection can mostly occur in the form of respiratory tract infection or UTI mostly. Now, after the infection, next we come to the malignancy. After the immunosuppression, the risk of malignancy is also very high. Now, the increased risk of malignancy is high specifically for skin cancer and for the lymphoproliferative disorder. Now, in case of skin cancer, the squamous cell carcinoma is the most common. However, the basal cell carcinoma can also occur, and it has shown that the 50% of transplant patients will develop skin malignancy within the 30 years of transplantation. Therefore, we advise all the patients to protect themselves to protect the skin from the sunlight, and also advise for a regular visit to the dermatology for the review of their skin to detect any early malignancy. Now, the last but not the least is the post-transplant lymphoproliferative disorder. This is mainly by the proliferation of the B lymphocytes and caused by the EBV virus, and it mostly occurs by 1 to 3% of kidney and liver transplant cases. The risk for the lymphoproliferative disorder is the aggressive immunosuppression therapy, and therefore it is shown that the reduction in the cessation of the immunosuppression may cause the prevention of the PTLD. Now, the PTLD mostly present as a lymphadenopathy with involvement of the many extranodal sites like tonsil, liver, lung, and GIT, and therefore the chemotherapy, antiviral therapy, surgery, and radiotherapy can be used to prevent the lymphoproliferative disorder. Thank you, sir.
So it is almost a complete presentation. Again, I want to say something about the presentation. those two slides of classification of the agents and their mechanism of action that has been pasted, copy and pasted from Berilov's pages. So you should write it on your own. Don't copy paste it because it doesn't look good.
Hello, am I audible?
Yes, sir.
Yeah. As you said, that there are different regimes of immunosuppressive therapy. Does the therapy varies? Suppose we are doing a isograft from identical twin. Now there are a lot of living related donors, and now with this organ scarcity, there are a lot of unrelated transplantation. So will the therapy vary depending on the donor and the recipient? Got my point. You are doing a transplant from identical twin, and you are saying that this mostly matches. So will the therapy? Will the therapy same for all?
It depends on immunocompromised, and we will not go for the steroid therapy because it will further reduce his.
You see, a properly matched transplant from identical twin. In that case, the chance of rejection is less because you have a identical twin in transplant. But still, there will be some immunosuppressive therapy required. But if you are now, as I said earlier, that there are some situations when people are even doing incompatible transplantation. So in that case, the therapy should be more intensive. Dr. Orko?
No, I think the link was gone. The two things I want to add, the presentation was almost complete, but one thing I want to add now, again, the type presentation, those two slides,
Yes, sir.
the classification and the agents that has been copied and pasted from Berilov's pages. And you have, it should have been written.
Yes, sir. From next time, sir, I will take care of it.
Okay, all right. It's a good presentation. And one thing, you should write the classification of agents like calcineurin inhibitors, anti-thymus antibodies, this right like this, because
Okay.
it acts at different phases. Different agents acts at different stages. There is a flow chart in Berilov showing where it is acting.
Yeah.
And what is the normal effect on normal tissues? That also should be told.
Okay.
And there are some regimes of this immunosuppressive therapy. Okay, we continue with our program. As the whole of August, we have circulated the program. Okay, thank you.
Thank you.
Thank you, Dr. Orko.
Thank you, sir.
Thank you, Ronit.